And our last speaker in this initial session is going to be MEG DOHERTY. She is the coordinator of treatment and care in the Department of HIV/AIDS at the WHO in Switzerland. Dr. Doherty is a trained epidemiologist, infectious disease specialist, and brings more than 20 years of experience working in the HIV field. So Meg, please join us.
Okay, thank you. Thanks so much, and I know we have an exciting set of agendas coming after all of these opening speeches about the new science. So I don't have slides because usually I have lots of them, but I'm really, really honored and very thankful for being invited to make a statement and opening remarks at this really nice conference and pre-meeting. And looking at the agenda, I wish I could stay all day, but I will have to go to another meeting around integration of HIV and men and those activities as well towards the afternoon. But I really have been inspired by what I've heard from the speakers before me. Number one, that we started with, we need to put people at the center. And when we talk about universal health coverage, it's people-centered care. And I think this is going to be the key to as we move forward. And what have we been doing as UN agencies and other stakeholders? What have we been missing in this picture should be a question we always should be asking. I think from Dr. Goosby's presentation, I took away that we're failing to activate change because we've known what we need to do for ages. Lancet has told us, and many other very, very brilliant people are telling us what we need to do, but it's not happening. So what is the activation energy that we're missing in this room or in the global activities around TB and HIV and making these targets happening? And lastly, I think what we heard from Stop TB is we have to hold people accountable. We may be looking for $13 billion. Is that the only way to do it? And I might argue that it's maybe not the only way, that we need to move forward more about putting persons at the center and finding better efficiencies and working together around these. So and I think the other thing that we'd like to mention is that we're talking about walking towards global and national prevention targets. And despite that we've done so much together, what are we missing? And in particular, I think what we wanted to say from WHO, perhaps the HIV department has been missing. And so by being here, we're making a commitment to that 6 million persons who need to be on TPT or TB preventative therapy. That's our accountability framework, that's our responsibility, and that's why we're here today at this meeting. So what are some of the other progresses that we've made before? I think we've been able to look at ART and we've been able to scale up immensely. 62% of people living with HIV are now on ART. Millions of people, yet we're still having those dying of TB. And a third of the HIV deaths were associated or due to TB. And this year we've brought the HIV deaths down from approximately 900,000 to 770,000. We don't know how many of those are attributable to TB. And if it's more than a third, then we've made an error in this past year of not working towards reducing those deaths. And we have to look at what we haven't done there. We have to also look at trends over time. We're on a target for reduction of mortality due to TB deaths that should be around 75%. We're at 41%. So how do we accelerate the work that we're doing to make those targets? I think we also always talk about in these meetings that we know the solutions. We know there's strong evidence that you have to also use ARVs at the same time, use TB preventative therapy. The data from Temprano has now told us 6 years out, there is still a mortality benefit from TPT, and that was only 6 months of INH. It works with ART or without ART. So the fact that we're not using it is almost, as Dr. Goosby was saying, it's a moral challenge for all of us. What has stopped us from doing all of this? Also, there is now these great opportunities, and many of you may or may not know that some of our TB colleagues are sitting in WHO Geneva right now discussing, should we be looking towards 1HP? Can we be looking at 4R? Are there other shorter courses, regimens that might be that catalyst? And I think hopefully by the end of this year, we'll have some more tools in our toolbox, more of something that can catalyze moving forward in this area to really get more people accepting to take TPT. As we know also, there are lots of reasons why people don't take this up. And I think that perhaps we haven't done enough of that work that we do in HIV really well around civil society, around what are the structural barriers, what are the beliefs, and how are we going to change that? Because we have reluctance at every level. We have reluctance at program manager level, we have reluctance in the community, we have reluctance in clients, we have reluctance also in sort of who owns this the program. And I just want to state, we just last week had a meeting where we brought TB managers and HIV managers from 18 different countries around the world. We were discussing integration around using diagnostic platforms. And you know, the major diagnostic platform is the TB Expert, Cepheid. But the fact that it's called TB Expert is now coming is part of our challenge. We need to be able to use these machines to really fulfill universal health coverage. So we need to be able to maximize integration at the point of care where it's around the person at the center. And then from a programmatic perspective, we really do systematically have to discuss how we can share the responsibility. I believe also we can take some of the lessons that we've learned from HIV in terms of optimization. Optimization is we've tried to bring the drugs down, lower prices, to easy to take, 1 pill a day, maximum, all your drugs in a single pill, and that they can be used for children, for adolescents, for pregnant and lactating women without concerns of either safety or efficacy. And I'm not sure we've done the same for TPT, but that should be our goals. And I think that this might also help us as we move forward, because what we do in the HIV world is we don't necessarily save the best for last. We save the best for up front. So are we doing that always with our TPT regimens? Are we putting ourselves out there and maybe risking making some errors along the way, but to try to prevent more deaths and prevent more active TB? So as I finish this up, I just want to say we can't forget that we need to actually find our TB cases, so we need to be able to actively identify those using urine lamb or other approaches, and identify new diagnostics, especially for children, and so that we can find those who would be eligible either for TB treatment or should be having preventative therapy. From the HIV department, we want to say, and the WHO in general, that we're here and we're committing to taking on that 6 million. And we also want to commit to looking at holistically, supporting TPT, supporting joint TB and HIV program activities, looking at advanced HIV disease, and trying to reduce those unnecessary deaths. And I think we have a lot of work to undo some of these behaviors and beliefs. But certainly at our stakeholder levels, our program managers, but if we work together, I think we'll be stronger in the end. And I would say we might be able to bend that curve a bit more towards making our targets. And I think from clinics' perspectives, from clients' perspectives, from person-centered perspective, we have an obligation to do that. So thank you very much.